Super excited for you to show up to our talk about intrapulmonary percussive ventilation. And we're actually going to start, we'll introduce ourselves in a second, but we're going to start with a question, just to get to know the audience a little bit. And would like to just have a sense for, let's start with this. How many people in this room work in ICUs that use airway clearance of some kind on a regular basis? Okay. How many people use an intrapulmonary version of that or a percussive version of that, such as IPV or OLE or Metaneb on a regular basis? Okay. And then how many use that inside of a well-defined RT-driven protocol? Okay. Awesome. So the majority of this audience has some experience with using airway clearance and an intrapulmonary version of airway clearance, and 2 people in this audience use that in the context of a well-defined protocol. It's very interesting. Okay, good. Well, that sets us up for today's conversation. We're going to talk about intrapulmonary percussive ventilation in the context of managing critically ill patients. My name is Craig Swanson. I'm a pediatric intensive care physician from Sacramento, California. I work in the Sutter Health System and have many years of experience in utilizing both the VDR as well as IPV.
And my name is Brad Sexauer. I am a respiratory therapist. I'm a clinical education specialist with Syntec with 10 years of respiratory care experience at St. Louis Children's Hospital, where I primarily worked in the pediatric intensive care unit.
For our disclosures, I am recently become a paid consultant of Syntec. I came to this position because of the years of experience with IPV. So I was born into IPV long before I got sucked into this world.
Yep. Similar to Dr. Swanson, I am a clinical education specialist with Syntec, so that is my disclosure. But the reason why I'm standing here today is because I believe in IPV therapy and its effectiveness. My years in the pediatric intensive care unit, it was the airway clearance modality of choice that we felt as RTs was the most effective and impactful therapy regimen to treat secretion retention and atelectasis in our patients.
So we'll introduce ourselves a little bit more with just a bit of our story, and then we'll get into the nuts and bolts of the day. So I'm a pediatric intensive care physician, and how many pediatric ICU docs are there in here? Just curious. So we're about a third-ish. And in our world, intrapulmonary forms of airway clearance are fairly common, and I grew up in a fellowship where it was very normal for us to do that. I moved to an institution which was also very normal, but that institution was part of a larger institution with an adult ICU, which used very little airway clearance protocols and almost no intrapulmonary or internal version of a percussive therapy. We moved hospitals, and I think you just click through. We merged hospitals in 2015, and that brought the pediatric ICU much closer with the greater adult ICU world. That naturally brought all the respiratory therapists together. That brought a lot of community, that brought a lot of dialogue, and over the ensuing now 9 years, the adult ICU has adopted intrapulmonary percussive ventilation as their primary form of airway clearance, and we've gone from 5 machines to 23 machines over that time period. And now it's been embedded into our airway clearance protocol, which is actually driven by the adult side, and now at the pediatric side, we're catching up to how to use airway clearance protocols.
All right, so I'll give you a little bit of background with my experience with IPV therapy at St. Louis Children's. So indications, any patient that had increased secretion production, any patient that had roaming, patchy atelectasis, and then especially if that patient was on mechanical ventilation due to secretion retention and atelectasis, we'd pull out IPV. Some of the common patient diagnoses that we would use it on are cystic fibrosis patients, patients with neuromuscular diseases that were hypersecretive. Neurological patients are cerebral palsy patients, patients with bronchopulmonary dysplasia and bronchiolitis. The configurations that we use, and I kind of have them in order of how often we use them. So we did a lot of direct to artificial airway. We kept in that inline suction because it's going to be pulling out secretions as you're delivering therapy. We also delivered inline with a mechanical ventilator. We would switch that ventilator mode over to pressure control mode and deliver IPV therapy, and that would make sure that we're maintaining reasonable airway pressures. We would utilize the mouthpiece more so in our cystic fibrosis patients. Anytime you use the mouthpiece with IPV, you want to make sure that the patient can keep those cheeks splinted and tight so those percussions are going into the lungs. And then every now and again, we would use a resuscitation mask, but there's a little bit of a challenge there in keeping a good seal. It's a little bit of a backbreaker, bending over the bed to do that. But so we rarely did that, and we didn't know of the ability just to connect that Phasatron to the elbow of the BiPAP mask, so that's a little pro tip. If your patient is on BiPAP, needs airway clearance, go directly to that elbow of the BiPAP mask, and it's a much easier way to deliver IPV non-invasively. And then typical frequency of delivery for us, we'd always start Q4, deliver a 15-minute therapy. Then we'd start reducing therapy frequency as the patient got better. And we also had the VDR at St. Louis Children's. So the indication for the VDR was pretty simple. If a physician gave to a respiratory therapist, it was like, I want to do IPV every 2 hours. I say, let me go grab the VDR. And if you're not familiar with the VDR, VDR is basically bi-level ventilation. You're setting an average inspiratory pressure and time, and average expiratory pressure and time, and then you're essentially delivering continuous IPV therapy while ventilating the patient.
So I'll have to say there's a lot of varied experience here, the use of IPV, different modalities, different delivery systems, intubated patients, non-intubated patients. So today's primary outline is we're going to spend a little time discussing the mechanism of action of IPV, and I'm excited there's so many people here. I kind of thought I'd be talking to my mom and a friend of mine, so this is good. And talk a little bit about use cases and contraindications, a few little case studies. We're actually going to look at the different forms of percussive, we're going to call internal percussive therapies, and just do a little compare and contrast in terms of how they work, not so much in terms of efficacy. And then we're going to go dive into the literature, and we're going to look at some outcome studies, and we're going to look at some disease-specific studies, and then hopefully we'll summarize this at the end. So, we need to spend 1 second on indications. We have a pretty experienced group here, so most people are probably familiar with this, but bottom line, the indication is anytime you want to airway secretion removal, so airway clearance, lung mobilization or lung recruitment, secretions, et cetera, are the primary reasons why we use IPV. There are some contraindications, and the most obvious one that people are familiar with is anytime you think there's a pneumothorax or you think there's a high likelihood of having a pneumothorax, and other various reasons we can come up with for contraindications, but that's the one that's the most commonly, that we run into the most commonly.
All right, so here, one too many. So here is the suite of IPV devices, and so if you're familiar with the 1C, which is the red box, you're probably wondering where is my red box. The IPV1 replaced the IPV1C, essentially the same device. You have two knobs. You have an amplitude knob where you're adjusting to deliver the strength of the pulses that are delivered to the patient, trying to get good chest wiggle. And then you have a frequency knob on there, so which changes the pulses per minute that are delivered to the patient. And generally, we say go between fast, slow frequencies every 2 to 3 minutes. The IPV1 can be used to treat neonates to adults. It could be used in all the other configurations that I mentioned with the mouthpiece, mask going direct to the airway, in line with the mechanical ventilator. And then next to that, to the left of the IPV1, you have the IPV2C. And the first thing you'll notice with the IPV2C, there's more knobs. It looks a little bit more complicated. But what the 2C gives you that the 1 does not give you, it gives you a little bit more customization. So when we see IPV therapy that's delivered in the neonatal intensive care unit, usually they like the 2C because the big difference here is they can set that drive pressure or that operational pressure to 20, 25 PSI. Your IPV1 has a internal drive pressure of 45 PSI. And so what that allows the clinician to do is when they adjust those percussive bursts of air that they're delivering to the patient, they could be a lot more gradual with that delivery, which is what you want in your neonatal population. The other knobs that you have on there, you have demand CPAP. So if you want to add a little bit of CPAP on top of those percussions that you're delivering to the patient. And that helps treat if the patient looks like they're tugging, they look a little air hungry. That additional CPAP can help with some dyspnea that the patient may be feeling. Also, if you're disconnecting from the mechanical ventilator and you're having trouble reaching the same mean airway pressure that they were receiving on that ventilator, you can use that demand CPAP. Sorry, I'm turning my wrist the wrong way. to the left to increase that demand CPAP to match that mean airway pressure. And then you have your IDE ratio that you can adjust as well. And then a lot of clinicians, I worked with IPV probably for 5 years before I realized it could be delivered at home. So that's what the green device there, that's the impulsator. The acute care, the 1C, the IPV1 and the 2C, they need that 50 PSI connection. The impulsator has an internal compressor, and it's basically the 1C, the home version of the 1C. So it's a great option. We had a lot of pediatric patients on the impulsator, and usually it was indicated when they would have multiple readmissions throughout the year, and they were getting vests or cough assists at home, and they needed a little bit more. Every time they would come into the acute care setting, they would get IPV, they would be able to go home, but then they would come back, and that's usually when we would talk about the impulsator.
So we're going to spend a minute now discussing the mechanism of IPV and how it works. And this is, so I had the pleasure of meeting Forrest Bird, who's the inventor of IPV and the VDR some years ago, and spent time with him to really understand and learn where his brain was at. And I came from a background in engineering and biophysics, and so it was a really wonderful match and experience. And the most important thing I learned from him first is something that in retrospect is so painfully obvious, it's almost embarrassing to say, especially with someone who's spent a lot of time in the world of physics and engineering, which is the simple concept that gas has mass. And so what that means is if you just blow into your hand, you can feel it. You can feel the wind against the breeze. The wind against the leaves. But gas has mass, and what IPV is essentially doing is creating pockets of energy delivered via momentum of air that can move things. Just like when you cough, that's essentially what you're doing. You're creating high velocity flow that creates shear and brings mucus out of your lungs. And IPV is essentially mimicking that, taking advantage of the fact that gas has mass, which means it has momentum, which means it can have energy, which means it can move things. Now, with that being said, of course, if we utilize the fact that gas has mass and we put high energy into the lungs, we want to make sure it's done safely. So the second most important thing, or maybe equally important, that I learned about IPV and the VDR, next slide, was what the Phasatron does. So in order to understand IPV, you have to understand the Phasatron. So we're going to hone in on that for a little bit, not knowing exactly everyone's familiarity with it. But what the Phasatron is essentially, liken it to the hands of an anesthesiologist. So an anesthesiologist managing a patient with bag mask ventilation or any form of ventilation is actually reacting to that patient, is delivering support to that patient, and at the same time protecting that patient. Well, the Phasatron is mimicking a lot of those actions, but with physics and with mechanics. So what is the Phasatron doing? I'm going to kind of point to this. The first thing to notice is that little moving bit. We call it the sliding venturi. That has two really important functions. One is to open up the inhalation port, or the entrainment port, which is that air coming in from the top. And the second is to close the exhalation port so that all of that entrained air is going into the lung. And the third is to act to protect, and we'll get to that in a second. But the first primary job is driving that air through what we call the venturi, which accelerates the air and sucks that air and sends it to the patient. The second aspect, so the Phasatron amplifies the input signal that's coming in through there. The second thing that Phasatron does is protect the patient or react to the patient. So this spring is finely tuned so that were there to be a back positive pressure at the end for a patient cough or too much pressure in the lungs, this will not close all the way and now allow access to the exhalation port. So the exhalation port with the Phasatron and VDR is generally at 0 atmospheres. So the PEEP, we'll talk about this in a second, is maintained in IPV through the delivery of continuous flow, continuous pulsatile flow, not through the restriction so much of air coming out. And that's an important distinction. So the Phasatron acts, in effect, like the hands of an anesthesiologist to deliver the flow and protect the patient.
All right, and I'm just going to kind of give a basic overview of all the parts of the Phasatron. So I have a Phasatron here with me, and we could just kind of pass this around. I was just going to hold it, but I was like, we have it up here. That doesn't make sense. So at the top of the Phasatron, you're going to see that we have an air entrainment port, and just like Dr. Swanson said, this is where ambient air is going to be pulled into the Phasatron, and it's being pulled into the Phasatron because of that high velocity flow that is going through. It's reducing the pressure inside that Phasatron, and then also at the end of the Phasatron, you have a patient breathing in, and you have that negative pressure, and so that makes the IPV and makes the Phasatron good at responding to changes in patients' lung compliance, lung volumes, and resistance. You also have that sliding venturi that Dr. Swanson said. It's moving forward, making sure that inspiratory pulse is delivered to the patient, moving back and allowing access to that exhalation port so the patient can freely exhale. And that is important to not restrict that patient's ability to exhale because that will help maintain secretion mobilization. The characteristics of the pulsatile flow that are delivered to the patient are going to help get flow behind those secretions, help shear them away from the airway walls, and help mobilize those secretions. We also know that there's a little bit of countercurrent flow that is happening that's going to help mobilize secretions as well. And then the nebulizer, where you're going to deliver normal saline or prescribed medication, mainly to keep the airways hydrated. And so here we have a good demonstration of how IPV can be effective in treating the diseased area of the lung. So the majority of your patients in the ICU are going to have a heterogeneous lung disease. And we know that when they're connected to a ventilator, that bulk flow is going to take the path of least resistance. So it's going to go to those more compliant areas of the lung, and it's not going to go to those non-compliant disease areas of lungs. So that's basically what we have demonstrated here in an extreme way. We have a compliant test lung, and then we have a glass bottle with confetti at the bottom of it. And so you don't see any air movement in that non-compliant glass bottle connected to the mechanical ventilator. When we connect this to the IPV device and we're delivering those high velocity percussive bursts of air, we could see how IPV is effective at treating the diseased, non-compliant areas of the lung. So now you see confetti movement in that glass bottle, but you also see that compliant test lung remains inflated. It's not hyperinflated. And so this is the goal of therapy with a lot of our patients in the ICU with heterogeneous lung disease. We are trying to treat that diseased area of the lung. And when I teach delivery of IPV therapy and trying to optimize therapy, one of the main questions I get is like, how do I know I have good chest wiggle? Well, one, you're going to visualize it, and then two, you're going to auscultate. And so if you have a chest x-ray and you know which areas you're really trying to work with, leave a hand on that amplitude knob, increase it, and auscultate over those areas of lung disease until you hear those pulses, and then now you know IPV is treating that area.
I love that. I love that demonstration because it reminds us of something extremely important about delivering pulsatile flow into the lungs, which is theoretically you can ventilate a patient or a scenario with zero compliance, like a water bottle, because what you're doing in effect then is creating a continuous inflow and outflow utilizing pulsatile air. So the air is continuously replenishing the alveoli at a rate that is faster than the normal flow of blood through the alveolar spaces. So we can get into that later. It just reminded me of that basic concept. It's really quite extraordinary. So as you know, when we're managing patients in the ICU, they come in for a variety of reasons, a variety of diseases, bronchiolitis, ARDS, it could be COPD, it could be some pneumonia or whatever. And then we put those patients through complex, difficult situations, right? We intubate them, we sedate them, we do all sorts of horrible things to them. And now they're susceptible to atelectasis, they're susceptible to secretion development, they're susceptible to hyperinflation. So can we use IPV to help prevent those secondary consequences, treat a little bit the primary disease by helping remove some of those secretions and potentially improve outcome? And that's what we're going to explore next.
Perfect. Yeah, so before we get into the deep dive of the literature, so a couple of use cases here where kind of sets reasonable expectations for IPV therapy. So here we have a PICU case study. This patient came in with left side collapse, atelectasis. This is a 3-month-old patient, ventilator dependent. And the present situation, the patient came in needing a little bit more support, put them on conventional ventilation and started IPV therapy. So you see that initial chest X-ray, left side whited out. After 16 hours or 4 treatments of IPV therapy, you start to see that left side open up a little bit, some aeration in that claustrophrenic angle. And then after 40 hours of therapy or 10 treatments, that left side starts to open up. And this is kind of a reasonable expectation for IPV therapy. You're going to deliver it for 24 to 48 hours before you start to see an improvement in your patient's X-ray. Here's a good adult case study. So this is an adult patient with COVID pneumonia, history of end-stage renal disease, admitted for respiratory failure secondary to COVID pneumonia. This patient had 2 previous failed extubations, and they started talking to the patient's family about this 3rd extubation. If the patient does not fly, we're going to do a tracheostomy. And so before they extubated the patient, so on the 20th, they started IPV therapy, TID, and you could see the X-ray to your right, so pretty hazy, not much going on in the bases. The patient was on mechanical ventilation, requiring a high FiO2, PEEP of 8 on volume control. So they are delivering IPV therapy, and then on the 22nd, they started weaning the patient's settings down to pressure support with FiO2 of 40%. You could see that the chest X-ray is improving, looking a lot better. We're weaning our settings. And then the patient was extubated later that day to vapotherm, so high velocity nasal cannula at 35 liters, 60%. They continued to do IPV TID with a resuscitation mask. And then the next day, this patient was down to a nasal cannula of 6 liters per minute. So pretty good case study there. This is another case study that was shared with us. Not a whole lot of information here, but a good demonstration of how IPV therapy can be used in line with mechanical ventilator. So this patient came with left-sided collapse. They did 2 therapeutic bronchoscopies. They were unable to open up that left side. They decided to get a little aggressive and do 1 hour of continuous IPV therapy, and they were able to open up that left side. One thing I'd mention, if you decide to do something like this, IPV does not have alarms. So do not leave your patient's side and get in order. But typically, we just recommend 15 to 20 minutes. But in this patient's case, it was beneficial. And then we have another adult case study. So IPV connected to the ET tube to treat atelectasis. This patient was on very high ventilator settings, high FiO2 requirement, high PEEP. Left side, left lower lobe, not looking great. Left upper lobe, not looking great either. Hyperinflated on that right side, compliance not very good. Then they did 5 treatments of IPV therapy, 1 bronchoscopy. They were able to start weaning those ventilator settings. They got down to a PEEP of 7 from 12, FiO2 of 100% down to 45%. You could also notice on that right side, that doming of the diaphragm where it was previously flattened. So better compliance after 5 therapies of IPV and 1 bronchoscopy. And then this is kind of an extreme case. So this is, but it highlights how IPV can be used with connected to a BiPAP mask. This patient was spontaneously breathing on BiPAP, but had a complete collapse of that left side. After just 1 IPV therapy treatment, they probably removed a big mucus plug sitting in one of the main bronchi and started opening up the left side of that lung. But again, it's kind of an extreme case, but shows how IPV could be beneficial even in those patients who are on NIV.
And in any group of a community of our IPV users, we all have our stories of seeing the response. So we can come up with some. I'm sure everyone could share, if you have a lot of experience, some experience you've had by utilizing percussive ventilation. But now we're going to dive into the literature. And before we do so, we're going to, here's the approach we're going to take. We're going to spend a little time looking at some of the different devices, and we're going to look at some bench studies, which are pretty interesting. So we'll spend a little time in bench studies. We'll do some review of some of the systemic reviews. and then look at some outcome studies, some disease-specific studies. But before we do that, we just want to be honest about the literature. There's no slam dunk study on IPV, and sounds like many people here in the user community, we've all been wanting that for years, and it doesn't. So we're not going to be able to give that presentation. The literature that we do have, though, is actually, I would say, more impressive than we might realize. And so we're going to try to put that story together. One of the challenges in the literature is actually there's different modalities or different versions or different machines that people use. And in the literature, it's not always clear which is being used unless you get pretty deep into the method section. And in the systemic use, there's really no effort in general to differentiate from the different ways of delivering internal percussive therapies. The patient population is very heterogeneous. But in some ways, there's some strengths here, because when you review the literature, you'll see it's used in a wide variety of patients. So first, we'll start with just a little bit understanding the differences between what we're calling today external percussive therapies versus internal percussive therapies. And what we're trying to distinguish, because this is what the literature is, most of the studies do, is they try to compare utilization of an IPV device versus more traditional chest physical therapy of some kind, whether it's traditional postural drainage or some more focal chest physical therapy versus VET therapy, used in various contexts. So we're going to use, for the sake of this discussion today, this framing of internal versus external percussive therapies. The internal percussive therapies are both the IPV device, which we've demonstrated here, and the one that's principally studied in the literature is a device called the Metineb, which is that one, which uses some of the similar properties with some small distinctions. There are other, people use the term OLE for oscillatory lung expansion therapies as well, but we're putting those into the bucket of therapies that use airway internal percussion to do airway clearance. And so now we're looking at just those devices that do what we're calling internal percussive therapy. And there's really several different versions. On the left, we have what we call intrapulmonary percussive ventilation. And then the other ones which use something typically called OLE. The two most similar are the ones on the far left. That is the IPV device and the Metineb. They call it also IPV. Sometimes it's called OLE, and that can be very confusing in the literature. So you just need to be aware of that when you're reviewing these things. There are significant differences between these on these different components. On the left, there's differences in the way the pulse flow is created. In the IPV and in the Metineb, it's created through a complex circuitry, a pneumatic circuitry with resistors that create time-cycled flow. Whereas in the others, it's more like a jet ventilator with a continuous flow and a flow interrupter. There's differences in the venturi, whether there is one or isn't, or how it's done. So for example, the difference between the Centec IPV device and the Hillrom Metineb device is whether or not the venturi slides, like I described earlier, or whether or not it's fixed. So in the sliding venturi, you get the advantage of isolating the inspiration from the expiration, whereas in the fixed, there's a resistor that defines how much flow goes out into the atmosphere. That is not relevant for the other versions. In terms of how you control, the IPV has, the Centec device has lots of knobs you can move and manipulate, whereas the others are a little bit more fixed. There's advantages and disadvantages to that. Some people like the knobetry of it, and you can tweak and kind of be like an artist, and other people like the simplicity and the control that you have with some of the other devices. And then there's differences along the exhalation. So I demonstrated the exhalation port earlier on the IPV device with the Phasatron, and the other devices have other ways of managing the exhalation side. The key distinction being with the Metineb and the IPV is the exhalation port opens up completely to 0 atmospheres. And there's no fixing of the downstream or the exhalation resistor, which is how it's managed with the Metineb. Next slide.
All right, and so now we have a couple bench trials that are looking at these different devices and seeing what that means for secretion mobilization. And I think when we talked earlier about the IPV mechanism of action and how we're able to not restrict the patient's ability to exhale, we have that sliding venturi that's moving back. We're also creating a little bit of countercurrent flow that may help improve secretion mobilization as well. And that's exactly what these bench studies are looking to assess is secretion mobilization. So this first one here, what the researcher did put simulated mucus into a balloon, pretty simple, connected a endotracheal tube to that balloon, and then performed IPV therapy or performed OLE therapy with the Velara. And then after 10 minutes of therapy, took that balloon and measured the post weight to see how much secretions were removed from that balloon. And they did this in line with mechanical ventilator and direct to the airway. And so what they found was with IPV, it was able to remove more of the mucus out of that balloon compared to the Velara device. So you see 55% decrease in the weight of that balloon when they delivered it in line with a mechanical ventilator, and 62% decrease in the weight of that balloon when connected directly to the airway. And kind of similar to that study, another bench trial, again, just looking at, okay, what do these flow characteristics mean, and what does that mean for mobilizing secretions? And so what they did here is they had a clear tube representing the airway. It was a 10 millimeter inner diameter tube, and they inserted simulated mucus into the middle of this tube, allowed it to settle. They set the simulated lung to simulate a CF patient with a static compliance of 45, resistance of 17. And when those simulated secretions settled, then they wanted to measure movement of those secretions. They attached it to a percussive neb, a metaneb, and an IPV, and then measured movement. And they did 30 seconds at the highest and lowest frequency settings for each device. They did 5 trials of this, and they took the best 3 out of 5 trials, and they found that with the percussive neb, it actually pushed that simulated mucus towards the lungs. The metaneb kind of stayed in the same place, and the IPV moved those secretions out towards the patient, which is what we want when we're trying to get secretions out of the lungs.
Perfect. So our industry, as you know, has a spectacular history with studies that work fabulously well in someone's bench and may work fantastically in a mouse and are spectacularly useless in human beings. So is this actually useful? Well, there are many, many reviews that have been put out. The 3 largest are these right here, 3 systemic reviews that look at pediatric populations, a variety of various disease entities, and COPD populations. We're not going to go through all the details on this slide, but point out some of the critical findings. So one of the most important things you'll see when you review all of these systemic reviews is the utilization of IPV in multiple contexts with multiple delivery systems and multiple patient populations: pediatric, bronchiolitis, COPD, ARDS, intubated, non-intubated. I'll point out the vast majority of these studies are in non-intubated contexts. There are a few studies in intubated contexts. We'll be discussing one of those briefly. The other thing you will notice when you just looking through the broad swath is there's actually a fair amount of studies. It's not huge, but studies that sort of met the criteria to be part of a review. There's 34 studies represented on this slide. So reasonable, not great. There's some themes through the studies. Number one is IPV, or these sorts of, again, I want to make the caveat that these studies include both the IPV device with the Phasatron that you're seeing, or the earlier version of it, as well as the metaneb device. And they're intermingled, co-mixed, and it's really impossible to tease out the differences within the literature. So we're not even going to try today. But the other thing you'll notice across the spectrum of patients, across the spectrum of disease, and all the studies these studies represent about 1,000 patients or more that are made it in the study, and on the order of 10,000 or so treatments that made it in the study. And the safety profile is nearly perfect. There's one mention of one patient in all of these studies who might have had hemoptysis related to IPV. And that study, they don't really know. It's just they had hemoptysis in and around the time. So the biggest takeaway from here is that IPV is safe. It's very safe, and if you've ever used it, you will know that. It's very safe. If you ever used it on yourself, you'll know it's very comfortable. And it's been used in many, many patients, in many, many contexts, with varying degrees of success, which we'll get into now. So here we're going to focus a little bit on probably one of the most important outcomes that we all manage in ICUs. Everybody here is in an ICU. We know we're under a lot of pressure to reduce lengths of stay for a whole variety of reasons. We know that length of stay obviously decreases cost, and we also know that length of stay, decreasing length of stay decreases exposure to risk. So decreasing length of stay can have a significant benefit for our patients. So we're going to focus a little bit on that. Embedded in these studies are some signals that suggest to us that these intrapulmonary type airway clearance therapies can in fact reduce length of stay. The signal's not perfect, but the signal is decent, and we're going to explore that for a minute. So we're going to look at both ICU length of stay and hospital length of stay. So in the ICU length of stay, there's been several papers by several authors from various locations. We'll focus a little bit on the WIN paper from 2019. This is a very large prospective observational study with a couple hundred patients in each side of that prospective cohorts. And they discovered a non-significant difference in ICU length of stay of about 2 days, non-significant. Unfortunately, the paper does not provide for us its p-value, so I don't know if it's a p of 0.06, but it's a substantial non-significant difference. In the hospital length of stay, however, they did achieve statistical significance, and that's referenced here. So the paper below here and here are the same paper in which they had about a 2-day, didn't sound right, a 2-day decrease in hospital length of stay with the utilization of IPV, and this was versus external percussive therapies. In this case, it was S primarily. So, and then the Antoglia study from 2006, they demonstrate a pretty impressive decrease in length of stay. Unfortunately, that was only versus a historical control. But a difference in length of stay both in IPV versus the historical control, and a difference in IPV versus their version of external percussive therapy that they were using. And finally, there's a more recent study, which I'll highlight with, is the Hassan study from 2024, which is actually, honestly, probably the best study that's come out yet. It's thankfully fairly recent, about 50 patients in each arm, and they showed a significant 2-day reduction in length of stay by the utilization of IPV over their traditional CPT. So 2 days out of 5.5, so a near 40% reduction in length of stay in their ICU, all comers, respiratory disease, not intubated. Now embedded in here, embedded in the WIN study is a provocative piece of information, which is that is the only study that made it to this level of review that included intubated patients. And they saw a near 2/3 reduction in mechanical ventilation time with the utilization of IPV, from around a 94-hour mechanical ventilation to around 30 hours. So pretty impressive result. Not fully prime time, but still very suggestive of the potential benefits of this form of airway clearance therapy.
Right. Perfect. So now that was kind of a general overview of kind of systematic reviews and then looking at length of stay. The following studies that we are going to assess are going to be IPV therapy specific, where they use an IPV device. And generally with IPV, we are saying it's going to be good at removing secretions. It's going to help treat atelectasis. And then you'll see in a few studies it's been beneficial in reducing hyperinflation in COPD patients. So the first one we have here is done on Duchenne's muscular dystrophy patients that were hypersecretive with tracheostomies. Small study, 8 patients in this study, a crossover study, and they looked at the AMCT sequence versus the AMCT sequence with 5 minutes of IPV therapy. And what that sequence involved was a forced expiratory flow technique and manual cough assist. Then they suctioned, and then they delivered a 5 ml of normal saline. Then they did the AMCT technique again and suctioned, let the patient rest for 45 minutes, did AMCT again, and then suction, and then measured that wet sputum weight. They compared that AMCT sequence with the addition of 5 minutes of IPV therapy, and you could see with the addition of IPV therapy, they increased secretion mobilization. You had a 68.7% increase with the addition of just 5 minutes of IPV therapy compared to 7% increase with that AMCT sequence alone.
And so another question that comes up all the time is whether or not there's a utilization in atelectasis. Here's an older study, a small study from a pediatric ICU. First, it was a retrospective evaluation of IPV versus, in that case, it was CPT. and compare. Sorry, this was pre and post IPV, looking at atelectasis with an atelectasis scale, which was quite nice. So they built that atelectasis scale, and then they turned that into a very small but interesting. Oops, sorry. It's missing it.
Yeah. Oh, down.
Down. There we go.
Yeah.
There we go. They turned that into a very small but a little bit provocative prospective study, and they looked at the delivery of IPV and looked at this using this atelectasis score in two groups, one with CPT, one with IPV. Only 12 patients in the study, but still a very provocative and impressive decrease in atelectasis with the delivery of IPV.
All right, so the next couple studies we're going to take a look at are in COPD patients. These were 33 exacerbated COPD patients with mild respiratory acidosis. That was defined by having a respiratory rate greater than 25, pH being in between 7.35 and 7.38. And they had two groups here. They had one group where they were receiving IPV therapy in addition to standard COPD therapy, and the other group receiving their standard COPD therapy, which was albuterol Q4, Atrovent Q6. They did IV heparin, IV corticosteroids, and antibiotics. But in comparison to these two groups, we see that 35% of the patients in the non-IPV group, their exacerbations worsened, and that was defined by a pH less than 7.35 and the need for non-invasive support, compared to the IPV group where none of the patients' exacerbations worsened. So what sort of effect did that have on length of stay? And we see a 1-day reduction length of stay with the COPD population treated with IPV therapy. They also looked at secondary outcomes as well. And you could see that in the entire group, in the IPV group, you had a reduction in CO2, you had an increase in PaCO2, and you had a reduction in work of breathing represented by respiratory rate. So generally saying that IPV is safe to use in the COPD population, which this is something where when you look at a patient who is hyperinflated, you get a little nervous about delivering positive pressure therapy. But in this case, and especially what Dr. Swanson is going to show in this next study, is how it can reduce some of that hyperinflation that's going on.
So this is a very interesting study. We're not going to get too into the weeds on it because it's actually they set up quite a complex system to evaluate. But the question they were asking is does IPV reduce what they call expiratory limitation? And so in other words, for a COPD patient in which dynamic compression and exhalation is a significant problem, does IPV help with that? And they created a mechanism to measure it using an externally applied negative pressure, and to see whether or not with the externally applied negative pressure you get increased flow on exhalation. And in this, the way it's set up, a larger number is worse, a smaller number is better. So 65% is worse than 35%. So they applied IPV to these patients post-extubation and asked the question, did it improve so these are all patients who'd been intubated in a critical care and post-extubation. Did it improve this is what they call the EFL. And in 25 patients, there was improvement in 24, and the one who didn't improve already had a pretty low value, and that's the one on the far left here with the value of 30. And some of these improvements were quite significant. In other studies, they've shown that this measuring actually helps predict whether or not patients will worsen after critical illness. But a pretty impressive study showing that there was a significant improvement in this measure of how able a COPD patient is to excel their air. And then naturally, with many of these studies, they confirm the physiologic improvements. So as we've seen in both the systemic reviews and other studies, in general, IPV improves your physiologic parameters.
All right, in the next study that we have, again, on COPD patients and IPV therapy, unlike the previous two studies, these patients were in an outpatient clinic. They had severe but stable COPD. There were 60 patients in this RCT trial, 20 in the control group, 20 in the VEST group, and 20 in the IPV group. And they looked at breathlessness, cough, and sputum scale score and compared pre and post scores with the VEST and IPV. And you saw an improvement in both the VEST and the IPV. They also looked at the dyspnea scale, which is a 0 to 5 scale looking at dyspnea during activity, 5 being the highest, and you saw an improvement with IPV and with the vest. And then you have the COPD assessment test, which is assessing 8 different factors, scale of 0 to 5, 5 being the highest. So the highest score that you could get is a 40. The lower score, the better. You've seen an improvement with the vest and IPV therapy. So both showing significant improvements in test of dyspnea, daily life, and health status compared to the control group in this study. They also looked at some PFT measurements, and we kind of pulled aside the PFT measurements that really represent a decrease in air trapping. And so the first one is residual volume. Obviously, if you have a lot of air trapping, you have a high residual volume. You want to try to decrease that. So you see a decrease with the vest and IPV therapy. They looked at total lung capacity. You know, if your patient is hyperinflated, they're going to have a bigger total lung capacity. We want to remove some of that hyperinflation, so we want to remove some of that total lung capacity. You see an improvement or a decrease with the vest and with IPV. Then they looked at FEV1, the ability of the patient to exhale within that first second. That's going to represent ease and an ability to exhale. You saw an improvement with the vest and with IPV. And then finally, they looked at forced vital capacity. And that's, again, the ability of the patient to exhale. If the patient has more vital capacity, that means they have less air trapping, and you want an improvement in your forced vital capacity. So you see both an improvement in the vest and the IPV therapy. And then the final study we're going to take a look at is how IPV therapy can be used prophylactically. This study was done on 18 pediatric patients with neuromuscular disease. They had 2 groups. They had one group where they were just measuring and doing IS exercise at home, and then they had the IPV therapy group. And what they were looking at is they were trying to assess a decrease in infections. And so they followed these patients for a 7-month period of time, and they found that in the IPV group there was no infection, so therefore no days for antibiotic use. In the other group there was 3 infections, so 44 total days of antibiotic use, 8 days in the non-IPV group for hospitalization, and 5 school days missed in the non-IPV group compared to 1 in the IPV group. So it really highlights how IPV can be used at home for those patients who really need that continuous airway clearance prophylactically.
So we're going to summarize some of the lessons from this literature review. And if you kind of back out and say, what is it that we're suggesting? Real simply, if you're not using airway clearance techniques, you should. We think the literature strongly supports that. If you're only using external airway clearance techniques, you should probably strongly consider moving to intrapulmonary versions of airway clearance techniques. And if you're already using those, this we didn't get into today, it's time to really start thinking about how we can make that more normal and more protocolized part of our usual management. So just reviewing, with that context, reviewing some of these studies, here's some questions that we've raised today. Are internal percussive therapies more effective than external percussive therapies? Our answer is maybe. And for people who've used these devices, it probably depends a lot on the severity of the illness and the amount of secretions. Does IPV therapy effectively loosen and mobilize secretions? We think the answer is a pretty strong yes, both from the clinical experience and the bench studies. Does IPV therapy improve PFT results? Most likely. We've seen several studies that show that. We demonstrated one today which shows at least an improvement in the various forms of PFT type evaluations. Does IPV therapy treat atelectasis? Probably. Both clinical experience as well as a couple of the studies we mentioned or alluded to or discussed in some detail show pretty significant changes in atelectasis with the utilization of IPV. But the most important questions are these. Does IPV therapy reduce post-extubation failure? We think it's a solid maybe. There's definitely a strong indication with the one study that we mentioned and also clinical experience in the IPV community. Does IPV reduce ventilator days? Again, one high reasonable quality prospective observational study with a very, very strong result suggesting that, in fact, IPV may reduce ventilator days, and it's a pretty decent argument for that. We need some more help trying to prove these things, so I'm hoping some people will hear this today and say, here's what I'm going to do to try to help answer these critical questions. And finally, does IPV therapy reduce ICU or hospital length of stay? And the answer is becoming a pretty compelling probably. Again, these are, we're bucketing all the various forms of intrapulmonary or internal percussive therapies into one, both the IPV version and the MetaNev version. But the studies are pretty compelling that, in fact, these sorts of intrapulmonary modalities for removing secretions, improving atelectasis, reducing hyperinflation, do indeed reduce length of ventilator days and ultimately ICU length of stay, and presumably, therefore, are benefits to our patients as we care for them. So we thank you so much for today. We have time for some questions to get into whatever detail anyone's interested in, and we really thank you for listening and for being part of this today. So we're here, we got about, what, 5-7 minutes or so, if people have any questions. Yeah, go ahead. Well, we're going to repeat the questions because there's no mic. Yeah, so the question is, are there cost-benefit analysis? And I assume you're referring to financial cost. Yeah, so there haven't been any that have been extraordinarily well designed. However, people reference them in terms of typical ICU cost per day. So obviously a 2-day reduction in ICU length of stay is a significant cost savings. Yeah. Yeah. Yep.
So
the yeah.
Yeah.
So the question is utilization of IPV in ventilated contexts, inline versus direct. So the controversy is, do you use a little inline adapter and throw IPV in through the circuit, or do you remove the circuit and do IPV directly? You want to comment on that?
Yeah. So it's a really good question. Is there a study that looks at that? The best you could do is go back to that bench study that showed a little bit more secretion mobilization direct to the airway. But I think another important piece to that is that we're trying to teach clinicians, users of IPV therapy, is that when you're delivering IPV therapy in line, make sure that you're adjusting that amplitude so you still get good chest wiggle. It may require a little bit more of an increase in that amplitude because you're delivering it through the patient's circuit and you're not going direct to the airway. So I think in a lot of cases, they're not increasing that amplitude enough when they deliver that in line, and that could be potentially a reason why you're getting like decreased secretion mobilization connected with a mechanical ventilator as opposed to going directly to the airway. And you may lose a little bit of a delta P too, just with the PEEP that's provided from the ventilator.
But I think most institutions have had success using both and develop a habit around it. And in some institutions, it's almost RT dependent, honestly. Some RTs like inline, some like direct. So those are areas where we need to start building more consistency of utilization protocol. So we're trying to help develop that consistency. Yeah. Sorry, what's that? It's a great question. So the question was, is there an impact on intracranial pressure? And there's two potential causes for that. One is increased intrathoracic pressure causing increased venous pressure on the outflow. And the second is, of course, your CO2 management. Yeah. So I have not seen actually a study that specifically looks at intracranial pressure. I have personally used IPV and VDR in the context of patients who are highly susceptible to those issues and have never seen any issue. The key thing is, as Brad was mentioning, when you're utilizing it, you're utilizing it clinically. You're utilizing it in the context of your patient, in the context of monitoring. So you can monitor whether or not you're elevating intrathoracic pressures with the delivery of the IPV, first of all, especially if you're using it in line. And second of all, you're actually if you overdo it, you're going to drop your CO2, which is potentially could cause reductions in cerebral blood flow. So the actual risk is not elevated ICP, the risk is hyperventilation causing poor cerebral blood flow.
Yep. And the other point to that too, if you work in a neonatal ICU, we generally say in those newborns within that first week of life, if they're premature, they lack that cerebral autoregulation, that you don't want to drastically fluctuate their CO2. You want to avoid too high CO2, you want to avoid too low CO2 for those reasons, because their cerebral blood flow is going to fluctuate. So if you do work in that area, we typically say that for those patients within that first week of life, hold off on IPV and fluctuating that CO2 for that reason.
Yeah. Oh, what a great question. So he's asking about ECMO, utilization of IPV and ECMO. Yeah, so actually, I don't think there's any IPV ECMO studies. There are VDR ECMO studies, which evaluate whether or not you can utilize VDR to maintain adequate pulmonary distension in that context. And those have at least proven safety profile. I've personally used IPV and VDR in the context of ECMO and have ran into a few little issues. Obviously, the concern that most people have is you're wiggling, especially in the context of a small baby, potentially wiggling near a precious cannula. And will it cause potential dislodgement of the cannula? And two, that wiggle could potentially introduce air because you have exposed to atmosphere. So, my personal experience, I've been pretty careful with IPV and VDR in those contexts for those reasons in the small patient population. In the larger patients in which you have a well-closed, sealed cannula and movement, microscopic or small movements are not as risky in terms of dislodgement, I've had no issues at all in using it. In the babies, honestly, I've been pretty careful to not use it in those contexts. Yeah. For a tracheostomy, when to initiate IPV therapy after a fresh trach? It's a great question.
Yeah. I think we typically hear 48 hours.
Yeah.
I think every hospital is going to be a little bit different and how much time they give that site to heal. But
yeah,
I think
you'd want to give it a little time to heal for sure. Just because you'd be introducing a fresh wound to potential pressure oscillations and potentially compromise healing. That's a great question, though. I love it.
Yeah.
It's a really good question. I actually don't know. I don't have a perfect answer for you, except obviously you should be careful and probably not do it right away. Yeah. Yeah.
Homogeneous. Mm-hmm.
Yeah. This is such a great question. I'll start with this one.
Yeah. So the question is there much of a difference between, I guess, like all the internal percussive therapies in different settings as well? All the studies that are available that have looked at that are bench studies that I'm aware of. There's no inpatient studies that are comparing one is better than the other. I think right now, at this point, what we know with inpatient data is that if you have a patient, you're differentiating between kind of those external percussive therapies and internal. The clear differentiation is, can the patient generate a forceful cough? Can they mobilize secretions on their own? If they can't, then do some of those internal therapies. But as far as like getting deeper into the weeds of which one's better on the patient, we can't say for sure.
Yeah, and this
outside of the bench studies.
The studies they're all single institution studies, so there's one or the other. So there has not been a direct clinical comparative study, only comparative bench studies. Mm-hmm. We believe that there's certain aspects of the IPV device that would lend towards a little bit more efficacy, but we don't have any way to validate that in a clinical context, only in a bench context. Mm-hmm.
Right.
Yeah.
Our team really likes protocolized things, typically less catering to specific
Yep.
patients than further, as opposed to something that we have to sit and adjust
Yep.
people are familiar.
Yeah.
So I'm just curious.
Yeah, no, that's one of the challenges with the IPV device and the benefits is it provides flexibility, which makes it a little bit more foreboding, and on the other hand, gives the expert practitioner a little more
Freedom.
panache.
Yeah.
Yeah.
Yep.
Any other questions? Yeah.
I'm currently a second-year critical care fellow, and I decided to study IPV for my research.
Oh, wow.
And
Fantastic.
I'm looking
Which device are you using?
the 2C
Okay.
at our institution, and I'm curious if you've come across much research about lung compliance and its effect on lung compliance specifically, because that's my question,
Yeah.
because I couldn't find much.
Yeah.
Yeah, that's probably true. I think there's one study on obese patients with compression atelectasis that showed an improvement in dynamic lung compliance. with IPV, but off the top of my
Well, there's
head, like there's other like kind of secondary findings.
I mean, the
that you
PFT
could
studies are
suggest.
proxy for
Yeah.
lung compliance, right? So in a sense, there's a general improvement in PFTs with IPV, which would imply an improvement in compliance, but there's not I know of a direct compliance measurement. Are these on intubated patients? Yeah, so you'll have access to a compliance measure on your intubated patients. So and will you at least do a secondary variable on a mechanical time of ventilation? Time of mechanical ventilation? Or make that your primary? Can you power to it?
I'm not powered for it, but
Okay.
I would love to if I could.
That's okay. We'll go with it.
Yeah.
We'll take it.
Yeah, no.
Okay.
It's a good design. Yeah. Nice.
Awesome. Yeah. Cool. Where are you working?
We're from Cohen Children's Medical Center in New York.
Okay.
Nice. Very cool.
Yeah, and we really don't use IPV often non-invasively, which almost never. Yeah, I think
Yeah,
I've
yeah.
seen us
It's
twice.
So it's easy to do. You can do it on anything. You can do it on a ram cannula. You can do it on a BiPAP mask. You can do it with a mouthpiece if you have a patient who can comply. Yeah, so you just throw it in there. And it just goes where it goes, so you don't have to worry too much about the delivery mechanism.
goes where it goes.
Okay.
Another question?
Yeah. Oh, what's that? No. Age restriction. Is there an age restriction on IPV? No. I've never heard of an age
No,
restriction.
and I think that it kind of goes back to your extremely premature
Yeah.
neonates.
The one thing I'd say is that there's obviously a potential risk here of shear injury with overdoing it. Now IPV is usually used in the context of intermittent management for 15 to 20 minutes, so you're not getting that continuous shear injury. So if used properly with the right amount of wiggle, there's probably very little possibility of causing any harm. However, I would say in a very fragile baby context, the continuous application of IPV certainly would have a risk of causing shear injury to the endothelium of the lung mucosa. Yeah, you don't need that. That you can easily recommend that is. I mean, one of the was mentioned in the systemic review was a bronchiolitis study, and the average age I think was 6 months, and they're looking at secretion removal basically, and they used it in very typical ways, very safely, and that was with the IPV 2C, I think. Yeah. Yep.
I've also been told similar to respiratory, that we should be careful in the hemonc population with platelets that are quite low for risk of pulmonary hemorrhage. It doesn't seem like any of your studies panned out that there was any safety profile to say that there was an adverse event of pulmonary hemorrhage.
Yeah, you're asking such great questions.
Yeah.
Are we seeing that?
Yeah. So I think.
In the studies, it was the one adverse effect that may have been caused by IPV. They had a COPD patient that had hemoptysis, but they couldn't definitively say was it caused by IPV, and that's after 38 studies with over
It's 10,000 uses or so of IPV in that study. It's been used. Who knows, right? We don't know. But I think what you're bringing up something really important is, and that's why I kind of, with the contraindications section, I put only the one that's like the most obvious. There's a whole bunch of potential contraindications like this that you have to use clinical judgment. You have to use clinical judgment. For example, the other night I had a patient who had the worst pulmonary hypertension I've ever seen, and also had atelectasis, and I'm like, I mean, we're max flow length, max INO, and the sinus drop was creating pulmonary hypertensive crisis, and I was like, I don't think so, because I don't want to drop the gas concentration, right? And so I think you have to use, so if I have a patient with severe, very low platelet count, where bleeding has been proven and a risk, frankly, I wouldn't use it. I would say, it's not worth the risk at that point. So there's boundaries where we need to use our clinical judgment, and we, as a community, probably need to establish some of those boundaries a little bit better. And I think our company is committed to trying to help create those boundaries, so you can have that kind of confidence to say yes and no in certain contexts, but you still need to use your clinical judgment. You are introducing a relatively high velocity of gas with associated kinetic energy and momentum that has the potential to cause injury if used improperly. Yep. With the bronchoscope? Yeah, I agree. I mean, I think it's probably safe, but I would understand the hesitation.
Yeah.
Yep, 100%. Yeah. Yeah.
So a couple of months ago, our institution actually stopped using inline IPV because I guess there was some reports of Phasatron because of air trapping from the company. But we have the red box IPV, and I was wondering what your guys' thoughts on that was because
Yeah.
we also don't
So.
use it on patients on nitric because I guess it gets stuck in the adapter. I don't know if it's the old one and that's what's happening. So I was just curious.
Great question.
So to address the first part of that question, there was misuse of the cap that came with the inline valve. What was happening is they were placing it on the expiratory port of the Phasatron when they were delivering it inline with therapy, and then forgetting to take off that cap when they went direct to the airway. So it was misuse, and that was obviously caused patient harm. So you can continue safely using IPV inline. There's no risk of pneumothorax if you're delivering. Well, I shouldn't always say direct, no, but it is safe to use inline with mechanical ventilation.
But you want to keep the exhalation port open.
Keep the exhalation port open. Yeah. So that's the big thing there. The second part of your question is with nitric delivery. We recommend that the Phasatron or the inline valve does not go in between. I think we're too close together. Does not go in between the patient and the injector module. So you want to go inline valve for IPV, injector module, patient. That will decrease how much the dosage of nitric is effective. There's other factors there too, the type of system that you have and whether or not that sample line that's at the patient is giving feedback to the module to adjust the dosage in the nitric depending on the flow. So it's understanding your device and then putting that T in the right location.
Which makes perfect sense, right? Because the entrainment will dilute your gas. So you want to make sure that the gas delivery and monitoring system is after the device.
And there's a couple bench studies out there looking at the Inomax system and one looking at the Genesol Vero tankless system. And comparing the two, the tankless Vero system is much more consistent with dosage delivery.
Yeah. So because you're delivering so much flow that the system has to catch up to get the concentration right, and that can take a little time. So there's a kind of a moment where you got to wait for the system to work. So I'm sure there's workarounds. I mean, you could crank, if you're at 20, go to 40 and then up it, so you could kind of do workarounds, but that's what's happening is you're diluting the gas, which is why I didn't do it on a patient on
Knox box. So, yeah.
That's why I didn't do it on a patient on 40 of nitric and 150 of Flowland. I'm like, I don't want to play with that 30 seconds or a minute long time. Yep.
Yeah. You're welcome.
Okay. Thank you guys.
Thanks everyone. Great
Appreciate it.
questions. Yeah.